All right. Good evening, everyone, or good morning. I'm so sorry that I can't be there with you in person. I got stuck due to some of the crazy travel and weather issues we were having in the Northeast. I was really looking forward to meeting some of you and learning about your experiences, but I hope that this will work as an opportunity to teach you all a little bit about congenital TTP and the state of the art of what's going on in TTP. So my name is Bev Schaefer. I'm a pediatric hematologist that focuses on the care of children and young adults with bleeding disorders and blood clots. I'm from Buffalo, New York, and I work at several different institutions, including a cancer center, a children's hospital, as well as a hemophilia center. There's a few of my disclosures. The only one I will just mention that is probably relevant for the talk today is that I do receive clinical trial funding from Takeda for a study related to TTP. And in today's talk, I will be discussing unlabeled or unapproved drugs. So today we're going to go over a few different themes. There's a section going to be on diagnosis, which encompasses kind of presentations that are common among pediatrics, as well as some things to consider in terms of genetic testing. There's a section on management that will probably be the most dense, where I'm going to share some really exciting information about new therapies that we hope will soon be available in congenital TTP. And then lastly, we'll talk about some long-term complications. I know this had been developed to be 3 about 30-minute talks, but you guys can feel free to pause whenever works for you or whenever you need a break. And I'm sure the moderators in the room can answer questions. All right, I'm going to start with a broad overview of congenital TTP. So as many of you are aware, TTP stands for thrombotic thrombocytopenia purpura. And this disease is the function, it results from the fact that there is a single protein that is missing or deficient, present in much lower quantities than normal. And this particular protein is known as Adams TS13, quite a mouthful. And this particular protein almost functions like a pair of scissors, and its job is to help slice up another large protein called von Willebrand factor. Adams TS13 is a really long word for a fancy name for this protein seen here, which is why it's a lot easier to say that than this big mouthful here. And TTP comes in 2 forms, as I'm sure you're aware, with congenital also being known as inherited, or genetic, or hereditary, meaning runs in families. This is something you're born with, even if it doesn't show up until later in life. The other form, immune-mediated TTP, is actually more common. And I know there's many individuals at the meeting this weekend who have immune-mediated TTP. Congenital TTP is considered an ultra-rare condition affecting about 1 person for every 1 million people. This is an under-recognized disorder. And we know that many individuals may have been thought they had something else for a number of years. Misdiagnosis is fairly common. And there may also be delays in diagnosis. This is a very common story among individuals with congenital TTP. And there's typically many years that may transpire because of the interesting nature of TTP. There are some people that may have some signs and symptoms in infancy that are managed, and then they don't provide any other clues, sometimes for several decades until another significant complication occurs. And we suspect that based on kind of some population-based data, that there's many individuals living with TTP who are either not diagnosed, or are misdiagnosed. So let's just kind of get back to what's the root of the issue here. So in normal individuals, von Willebrand factor, seen here in red, is typically secreted by our endothelial cells. And this is happening all of the time, but it also happens at a higher rate in states of stress or infection or fever. And when von Willebrand factor is secreted, it's secreted as these large, long strings. We call these multimers. And von Willebrand has an important job. It binds to blood vessels, it binds to platelets, it binds to other clotting proteins. And when it's secreted from our cells, it's secreted as kind of many different sizes, but especially extra large. And then it gets cut up into small, medium, and large size proteins by Adams TS13, which functions as a scissor, if you will. And when that happens, it's kind of chopped up into different pieces. Some of the platelets become unbound, and it moves along in our blood clotting system. But when this crucial enzyme, Adams TS13, is missing, What ultimately happens is these von Willebrand factor molecules accumulate. They kind of get stuck to the blood vessel wall, more platelets bind, so there's less platelets floating around and more are bound. And then inevitably more and more and more of them get stuck together. And this almost creates kind of a web or a network of these jagged particles. And as our red cells seen here try and pass through, they get split or fractured. They become fragmented. They no longer work as well. And this constellation of things ultimately causes a few things that we can see both in terms of laboratory assessments. Platelets are not available because they're all stuck to von Willebrands. This is called thrombocytopenia. And when we don't have platelets available, patients can have bleeding symptoms. We have red cells that are breaking open and becoming fragments in these little pieces here. This is what we call hemolytic anemia, breaking red cells into these small pieces. This is happening often within small blood vessels. And then lastly, when we have impaired blood flow or blockage, that really impairs oxygen delivery to organs and tissues, which causes damage to these tissues, whether that's our brain, our heart, our kidneys, and so on. These are the hallmark symptoms that are common among both patients with congenital as well as acquired TTP. This is a schematic showing the history of TTP. So, this was first identified in the early 1900s. We're literally only about 100 years at this point since it was first recognized, where patients were found to have this catastrophic occurrence of these microclots in circulation. In the 1960s, people began to appreciate that there was maybe some people who acquired this condition rather than being born with it. But in the 70s, it became more clear that we were probably dealing with two different versions of this disease, both a hereditary form and an acquired form. This was first named Upshaw-Schulman syndrome. Actually, it was first called Moskowitz syndrome, then Upshaw-Schulman syndrome. And that's when the first treatment with plasma was started in the 1970s. It really wasn't until the 80s, 90s, and even 2000s that we began to understand kind of some of the mechanisms behind this disease and some of the crucial proteins like ADAMTS13 and its role in cleaving von Willebrands, that this became more well understood. We talked about von Willebrands circulates in different sizes. You can kind of appreciate there in this small graph here. And the normal person is on the left. You kind of see this laddering effect with large at the top and then kind of extra large at the top above this dotted line, and then large, medium, and small. But you can see in a patient with congenital TTP on the right, above the dotted line, you have an excess of these extra large, what's called extra large or very large molecular weight multimers, which is one of the main issues in TTP. So what is considered a normal ADAMTS13 level? And I will tell you that even this remains debated. We generally think that unaffected individuals have levels above 50%, although there's been some recent debate that maybe it should be higher, 65 and 70%. So we're still kind of learning what's more normal in a population-based level. But without question, people that have congenital TTP have quite low levels, usually less than 10%. There are many individuals who have no circulating ADAMTS13 that can be detected, levels of about 0. Other people have levels somewhere in the middle. They can be measured, but in fairly low numbers. One of the things we've recognized is that the level that you may have in childhood may change over time. There are other proteins in our body that may decrease with age. This may be one of them, but it likely depends on our genetic mutation as well as some other factors. Perhaps our liver health, perhaps other medical issues we have may influence changing with age. And I would say this is something that probably happens over decades, not like you turn, 15 to 16, probably a cumulative effect over decades. As I mentioned before, this is considered an ultra rare disease. The immune-mediated form is much more common, as you can see here on the left, making up about 60% of cases. Congenital TTP just makes up about 5%. And again, really considered an ultra rare disease. So while even with immune-mediated TTP, we are still continuing to learn a lot. The group of individuals here today, your family members, really makes up a very small group. And so following each one of these individuals, learning as much as we can is tremendously valuable. I'd like to talk a little bit about where does our data in congenital TTP come from? These are some things we're going to be discussing over the course of the presentation today. So a lot of what people are interested in is long-term follow-up, and that's something that remains a challenge. So there are a few registries. Some of them are international, some of them are country-based, but I feel like it's important to just mention these because we'll keep discussing these. There is a statewide registry in Oklahoma that includes both children and adults with both congenital and immune-mediated TTP. It has just 3 cases of congenital TTP. The UK registry of congenital TTP as of 2019 has about 73 cases. Japan registry has 43 cases. And then there's an international hereditary TTP registry encompassing individuals from 19 countries. And as of 2017, it had 123 cases. And I just kind of share, these are the patients, this is what we have. So you add these all together, we're talking maybe 250 patients with congenital TTP that we have some data on. So that's where I'm going to encourage you, if you're ever approached about an opportunity to participate in data collection, we really need you. And we'd like to follow you and the course of your disease long-term so we can have more accurate information. And I'll just say there's obviously some caveats with this. We have very limited data on individuals over 65, and a lot of the data may not be what's called prospective, meaning it was done based on kind of memory or a retrospective approach rather than a prospective approach. Okay. One of the things we're going to talk about is the symptoms and presentations in children. So we're going to start with the case. So this is a presumably healthy full-term baby boy who developed jaundice or yellowing of the skin shortly after birth. He was irritable and had bruises on his heels, as well as low oxygen saturation. His labs showed evidence of poor tissue perfusion with acidosis. This is a sign that he's not getting enough oxygen to tissues, and an elevated lactate. His blood tests, so this all happened quite quickly. At 28 hours of life, his hemoglobin was noted to be low, platelets noted to be very low, and on the peripheral blood smear, so meaning somebody looking under the microscope, was noted to have 28% red cell fragments. That's quite abnormal. And his bilirubin or jaundice level was quite elevated at 32.8. This is really in what we call the danger zone. This can have a lot of serious implications on health, including brain health. So this is what a normal blood smear looks like. We see lots of nice round red healthy cells, these kind of small purple confetti-like cells with the black arrow. These are platelets. This is a white blood cell over here with the blue arrow. This is probably what this baby's blood smear looks like, and hopefully you can appreciate the difference. So first of all, you see the red cells. They don't all look nice and round and healthy. A lot of them are kind of triangular shaped, kind of confetti, not confetti-like, but just kind of irregularly shaped. These are those schistocytes. Those are red cells being broken as they're kind of passing through these jagged collections of these von Willebrand multimers. The other thing you can appreciate is, I don't really see a lot of platelets here. Maybe there's a few here, right here in the middle, but not very many. And that kind of fits with what we knew. This baby had a very low platelet count because they're all being stuck on those von Willebrand multimers. So hopefully if you can see this, I'm going to tell you have what it takes to be a hematologist. We'd love to have you. Oh, and this is just to point out again what schistocytes looks like. So the team ordered red blood cells, platelets, IVIG, and phototherapy. They were moving quite quickly to try and stabilize this infant while they were trying to figure out what was going on. But unfortunately, again, those labs were just at 28 hours. This patient continued to get worse, ultimately deteriorated, and died several hours later. An autopsy was performed, which was inconclusive, but somewhere along the way, somebody was suspicious and ordered genetic testing, which confirmed that this patient had 2 gene mutations, which were consistent with the diagnosis of congenital TTP. So this case is it's a challenging case. It's a sad case. And if this brings up any difficult memories for you and your family, I sincerely apologize. But I think that this case is really important for several reasons. One of them, I think this case really profoundly acknowledges how rapidly progressive organ failure can occur. And that because of the rarity of this condition, um, prompt recognition is imperative to avoid fatal outcomes. This team was moving as quickly as they could to help this baby. They were giving many therapies that we would give for babies with jaundice or babies with low platelets. But ultimately, this baby did not receive appropriate treatment for TTP. When it's identified, or when there's a family history or a suspicion in infants, one of the things we can do is what's called whole blood exchange transfusion. As we get older, many times we'll use plasma infusion, but sometimes this is not feasible for volume issues in infants. And I think this case illustrates the sad reality is that some patients with TTP may die before they're being diagnosed. So when do patients with congenital TTP present? The reality is at any age. It generally feels that there's two main chapters for presentation. Either the early onset form where patients present as neonates, as in this case, or in childhood. But there are some people that really kind of evade recognition until the adult years, not presenting until pregnancy, and occasionally even until the 50s, 60s, and 70s. We really recognize, however, that there seem to be two periods of really heightened risk. One of those is in infancy, as we just talked about. The other one is pregnancy. These are really significant periods where a lot of patients' disease becomes known. Excuse me. Why infancy? Why is this such a high risk period? Well, several things. Being born is stressful. Babies are transitioning from an intrauterine environment to an extrauterine environment. Sometimes we know babies have a little bit of a rocky entry into this world. Sometimes babies might have a difficult delivery, might have some issues with breathing, might have infections. These are things that happen that could exacerbate TTP. Also, babies undergo a pretty rapid and remarkable change in their circulation as they're transitioning from intrauterine to extrauterine life. And there's thought to be some turbulent blood flow through the neonatal heart, which can cause some additional shearing of red cells. Babies have a unique blood system that we think also could contribute to some thickness or viscosity of their blood. But babies are born with high levels of von Willebrand factor, especially those ultra large molecules of von Willebrand's. So when there's a patient that might be suspicious for congenital TTP, what are some of the things we can do to secure the diagnosis? The first one is that Adams TS13 level, but acknowledging that for many places in the country, this test may take several days to return. In major cities, they may have the option to do it same day, but many communities, this will take several days to return. Obviously, history is a big part of it, whether it's history within the patient or maybe a sibling, that could be really telling. One of the important things we have to do is rule out immune-mediated TTP, which is more common than the hereditary form. And then ultimately, genetic confirmation of having two mutations really secures the diagnosis. Symptoms are different at different chapters of life. So in the newborn period, as I mentioned, many of these babies will have profound jaundice or hyperbilirubinemia, as well as low platelets. In childhood, low platelets are much more common. Sometimes strokes are the presenting symptom of TTP in childhood. There's been a few cases of kidney injury as well, or patients with recurrent episodes of abdominal pain or really severe headaches. In adulthood, again, if somebody's really evaded, not shown any signs of their disease, it may be pregnancy that becomes the chapter where that's shown. Also recurrent strokes, or sometimes found by surprise, or if you will, found solely due to family screening. So I'm going to show you something that hopefully you can see, that in addition to the presentation symptoms, I just like to highlight some of the things, the similar conditions that generally are much more common that providers are thinking about. Because while severe jaundice to you all might sound like, oh my goodness, how could you miss that? The reality is there are other conditions that occur very similarly and are way more common. In childhood, for example, thrombocytopenia, one of the most common diseases that I treat is something called ITP. This is a platelet disorder, which is 20 to 50 times more common than TTP. And in adulthood, again, adults develop renal problems. Pregnant women develop preeclampsia and sepsis and something called HELP syndrome, which can really mimic and have a lot of overlap with some of these. So I share this because it's, providers are really working through what they tend to see more commonly and recognizing there can be a lot of overlap with other conditions. TTP certainly can affect many different parts of the body, right? This is ultimately a disorder of the blood and of the blood vessels. And our blood vessels are everywhere, but there's specific blood vessel networks where there's a little bit more of what we call microvasculature that seems to be especially susceptible. And those places are the blood vessels of the brain, the blood vessels of the heart, the blood vessels of the kidneys, the gut, and the eyes. And they really seem to be particularly at risk. And when there is blockage by all these, all blockage of these vessels, all of these structures can become damaged, and that damage shows itself in different ways. In childhood, the presentation is really often mimics ITP, which is a very common disorder. In children, the majority of patients present with low platelets, and low platelets can cause bleeding issues, like seen in the pictures on the right, like petechial rash, bruises, nosebleeds, blood blisters in the mouth, maybe heavy menses. This is commonly mistaken for ITP, which is way more common. Hemolytic anemia is the second most common kind of symptom children will have, but that occurs in less than a third of patients. Infection is the most common trigger seen in childhood. And then children can be diagnosed at all different ages. Again, some are recognized in infancy, all the way up to adolescence. So there's some challenges in pediatrics. If low platelets is the only symptom, and the low platelets get better, as they often do, it can easily be mistaken for ITP. This is the same story as ITP. Platelets, either with no treatment or maybe some steroid treatment, things get better. It can really be easy to see why this is mistaken. Neonatal jaundice, as we talked about, many different issues happening in babies can cause problems with jaundice or that yellowing, hyperbilirubinemia. But this is typically a short-lived stress. And there's been many cases of individuals with congenital TTP who have an episode as neonates and then nothing for decades. And that kind of gets forgotten about. And so again, my take home is that many children may be misdiagnosed at the current time or as part of their past story. It's a quick summary from the UK cohort. Again, on the left is showing the different ages that people presented. And just again, in their cohort of how many? I can't remember. 70 some patients, I think. Don't quote me on that. About 38% had childhood onset. But you can see in the UK, adult onset TTP, especially in pregnancy, made up over 61% of patients, really illustrating again patients presenting at all stages of life. So hopefully this kind of sets the stage that for individuals with TTP, this is a really variable disease. There's a lot of differences person to person, family to family, some with asymptomatic periods for years with no signs of disease until later in life. Some have minor symptoms going on frequently. Some have more frequent or quite severe symptoms. There's a lot of variability here. This is an important point. Thrombocytopenia or low platelets, even as little as a 25% decrease from baseline. So I'm not even saying low, might not even be flagged as low on somebody's basic blood count, but even a decrease from baseline can be a sign of disease activation, organ damage, and requires careful attention and ultimately treatment. So this is something that's been an evolving concept in TTP. And this requires a lot of thought because many times in other conditions, we don't really worry about the platelets until we're at the point that we need to transfuse. That's not what we're talking about in TTP. So it's important to know where your platelet count is on a good day and recognizing that even a 25% decrease is a sign something may be going on. So many people with TTP live with periods that their disease is relatively quiet, but ultimately exacerbations really are what tend to get people in trouble. Why do these exacerbations happen? So some of the more common triggers is anything that causes inflammation causes our von Willebrand's to be secreted from our cells. The most common reason is fever and infection, and this is the most common reason in childhood. Alcohol use, especially in excess, for reasons that are not entirely clear, can increase von Willebrand's factor. Pregnancy, this is a natural state where von Willebrand's levels rise. Hormonal medications as well, especially higher dose ones. Major injury. Surgery, that's another situation where you have, a wound or a surgical site, you injure tissues to either have to, when you have a surgery, ultimately usually to fix something or biopsy something, that causes von Willebrand's to be secreted. But many times, the cause of the disease exacerbation is unknown. This is a quick slide showing that in this study from 2021, in 131 acute episodes that were followed prospectively, they could find a trigger about 2/3 of the time. And the types of symptoms patients had included abdominal symptoms, fever, headaches, or neurologic things like stroke, confusion, kidney injury, and in 2% resulted in death. Another study looked at what were some of the triggers for some of these exacerbations. Females are in gray, males are in black here. And you can see that again, in a fair number of episodes, there was no trigger identified. Higher rates of alcohol-related episodes in male patients. Females, certainly fair number of them in pregnancy. And I feel like the other category included things like injury, surgery. I can't recall the other ones offhand. Children have the highest rate of events, and generally the incidence of acute episodes decreases with age. And as I mentioned, I think a lot of this may be due to infections. Children tend to get a lot more infections than adults as we're growing, going to daycare, school, all of those things. Let's talk briefly about pregnancy. We've brought that up a few times. So this is a chapter where we will meet many adults with TTP. This typically shows itself within the first pregnancy, and there's a strong genetic component, which we'll talk about. And you can see, depending on the cohorts, in the UK cohort, almost 70% of their adult presenting cTTP was in pregnancy cases. Depending on the registry, this makes up a large proportion of individuals. Pregnancy issues in patients with TTP are very, very serious, causing issues to mom, issues to baby, and ultimately some challenges with supporting the placenta, kind of the sac that supports fetal growth and development. So moms may develop preeclampsia, as well as something called HELP syndrome. And these are complications that can happen in other women as well, but unique in TTP is that they tend to be extremely severe and happening quite early, often within the second trimester, really early in pregnancy, resulting in extreme prematurity and sometimes fetal demise. Strokes and other clotting events can occur in pregnancy, which obviously can have devastating consequences. In pregnancy, many women develop some mild anemia anyways, but when you have additional anemia on top of what I call this physiologic anemia, can lead to some additional cardiorespiratory issues. Ultimately, these are very serious complications that can result in incredible risk to mom and risk to baby that may ultimately result in poor outcomes, including death. When there is ultimately kind of this microvascular occlusion, poor oxygen delivery to the placenta doesn't grow very well, it's poorly formed, and then it can't really support a healthy baby. And when there's an adequate blood supply, unfortunately, baby doesn't get the nutrients it needs. It doesn't grow properly. So this is incredibly, incredibly serious and really prompts aggressive management in pregnancy. So why are so many women diagnosed in pregnancy? So I mentioned this is another physiologic state where von Willebrand's levels rise, but there are quite a few specific genetic changes within the ADAMTS13 gene that really seem to be linked with development in adulthood. And I think one of the challenges too is that some women can also be misdiagnosed with other issues in original pregnancies before somebody puts the pieces together. Because there's a lot of overlap here, unfortunately, with some other very serious maternal health conditions. Okay. This is a point where you guys can pause and, talk about the pause and ask questions related to the first section. I'm going to move on to talking about the genetics of TTP. Okay, so on the left here, this is a cell. And within our cell, we have a nucleus, which is where all of our chromosomes live. Remember, we have 23 pairs of chromosomes. Each one we have one from mom and one from dad. And this is kind of a big one blown up, this blue X here. Within our chromosome is comprised of lots of DNA. So on chromosome 9, it's kind of seen here now in this kind of grayish picture, chromosome 9 contains DNA. And within this long chain of DNA, we have specific genes. And then within a gene, there may be a specific change or a mutation in the coding sequence. So TTP is what's called autosomal recessive. So starting at the top, we have a mom and a dad. And on the left, we have dad, who has one normal ADAMTS13 gene here in green, and one that has a non-functional ADAMTS13 gene. Mom has the same. Each time that they have a child together, there's several different combinations that can result. Mom and dad can both pass along the normal ADAMTS13 gene. There can be a scenario where mom passes on the normal one, dad passes on the abnormal ones, and vice versa, where individuals would be like their parents as carriers. But there's also every time there's a potential a pregnancy, they each have the potential to pass on the copy of the ADAMTS13 gene that has a change in it. And so a child can be born with two non-functional copies of ADAMTS13. So remember, some families, this is a common pattern in other genetic disorders we take care of. Every pregnancy, there's a 25% chance of having a child with TTP. Some families have said, well, I already have one. How do my second child have it too? Just because you already have one that's affected doesn't mean the next time around only these other three scenarios are relevant to you. Each pregnancy, 25% chance of having a child with congenital TTP. This occurs equally in males and females. There's no sex predilection here. And generally, this results from two mutations, typically one from each parent, as we just discussed about. There are occasionally some scenarios where when they go looking in the parents to learn more about where this may have come from within their family tree, sometimes it's only found in one parent, and one of the mutations is determined to be new. This is what we call a de novo mutation. This is something we do see in kind of the genetics of diseases like this, that sometimes we get unlucky when they're being put together inside mom and dad. We know that there's higher rates of TTP in families that may be related. This term is called consanguinity, or from individuals who come from really small ethnic groups. Sometimes these are island nations or more kind of secluded geographic groups. Just want to review a few genetics terms with you. So on the left here are two what's called wild type chromosomes in green. The next thing I'm going to talk about is people that are heterozygous carriers. These have one normal and one that has the change in it. These are often referred to as carriers. People who are carriers or heterozygotes are usually asymptomatic. Most parents of children with CTP are carriers, and I'm just going to acknowledge that this is a really understudied group. We could talk a whole half an hour about that, but we're not going to. Individuals that have the same mutation on both chromosomes are what are called homozygous, meaning they have the same mutation. And this is, again, more common when individuals are related or may come from small ethnic communities. And then there's something known as a compound heterozygote, where people have two different mutations, one on each chromosome. This is the most common scenario we see, which ultimately means that there's many combinations of genes resulting in the same disease. In terms of TTP, at this point, we have more than 200 mutations that have been described. And many are what are called private mutations, meaning that they're unique to certain families. They haven't found these globally or worldwide. They're from one family or two families. There's different types of mutations, something called a missense mutation. That's the most common type of mutation we see. So these are just kind of a silly exercise. If the sentence is the cat has two, a missense mutation changes a letter. It's a word we know, but that sentence doesn't really make much sense. A nonsense mutation, same thing. That doesn't really change it into anything we can understand. The splice site mutation, that kind of cuts the sentence off, if you will, ending it prematurely. And then frame shift deletions and insertions, again, you can see that really doesn't make any sense either. And ultimately, a lot of these result in something that can't really be read, and in our gene, that results in something that can't be processed. As I mentioned, there's over 200 mutations that have been described. There are a few mutations I'm going to highlight. And these actually occur with, if you will, a little bit more frequency than others. So you can see this one down here on the bottom, the R1060W, occurs in about 0.08% of the population. It's a pretty small number, but still higher than these other really rare mutations. But important to acknowledge that there's quite a bit of geographic variability here. There's higher carrier rates in Japan and central Norway. This particular mutation, this 4143 duplication, is pretty common in individuals who have ancestors from Central Europe and Scandinavia and Baltic Sea, where the R1060W is a little bit more widespread, is one of the most common mutations reported for many people throughout Europe, USA, and Turkey. So for those that some of you may have had genetic testing done and may ask the question, is there any association between levels and severity? And this is really tricky. You know, other diseases we follow, like hemophilia, there may be pretty strong correlation between levels and disease severity, but this is much less distinct or less clear in congenital TTP. We know that individuals whose levels are less than 3% may be more likely to present in childhood, are more likely to have more than one event a year, and require prophylaxis. However, there's a lot of variability. So if there's two individuals of a level of 3%, they may have very different lives. One with frequent symptoms diagnosed in childhood, one asymptomatic and not diagnosed until age 40. Even among siblings who have the same disease, the same genetic mutation, there can be significant differences in clinical severity. And there's likely other unknown factors that contribute. Maybe these are things within our immune system, our response to inflammation. Maybe it's the contribution of other health issues. There are things we're still learning about. Maybe it's environmental things. Maybe somebody smokes, somebody doesn't smoke. There's probably other things here we don't yet understand. How about our genetic mutation? What does that really, is there a correlation with our genetic mutation and levels? This is also incomplete, meaning if you know somebody's genetic mutation, can you predict their levels? It's difficult. So again, the R1060W mutation, people have been reported to have levels anywhere from 3 to 12%. And you can imagine there's probably a big difference whether you're 10% or 3%. And this is one of the more common mutations found in adult onset TTP and pregnancy. But again, one also recognized that levels may change with age, contributing to some exacerbations and strokes with aging as well. People that are known to be homozygous or have two copies of this particular duplication, they have very low levels, undetectable. But even people that have the same mutations, they're all homozygotes, there can be variable severity. So this really again illustrates, I think, that there's other unknown factors beyond just genetics that contribute to disease severity. There is a correlation between the location of the mutation and the age at presentation. And I think this picture probably shows it best. So this is a map from a few years ago, mapping the ADAMTS13 gene in the cohort from the UK. And on the top, so all of these are what are called the exons or different coding regions, and the numbers here in the white region. In the gray boxes at the top are different genetic changes. And then in this structure underneath, this kind of shows some of the different domains and perhaps that. This is what's called the spacer region. And even if you just kind of squint a little bit, you'll notice that things to the left, the people described in these little kind of teardrop shapes, the majority of them are quite young. You see many individuals, 0 months, 6 months, 12 months too. Post-spacer mutations, these are older age individuals. And when they're pink, these were pregnancy triggered. See a lot of these people, 21, 30, 29, 42, 39, really showing that there does seem to be a difference. These mutations in this region of the gene, probably a more severe form of the disease picked up in childhood, potentially in the changes in the post-spacer region, all these different exons here, they may be more associated with the adult onset type. This is another illustration from a few years ago that again showed for different genetic changes when people were onset of disease activity. So these are individuals who really hear this kind of line in the middle. The people to the left, these all show individuals whose level is less than 1%. You can see in this red box here, these are all neonates. These were all diagnosed at a very young age. But you can see there's about 20% of people diagnosed after age 20 who also have pretty low levels as well. To the right of the graph, you can see people who have levels of all different, ranging from about 1 to 7 on this graph, being diagnosed anywhere from age 5 to 20 to 70 years old. And these different dots correspond to some of the genetic mutations we discussed. So here's the take-home points. Ultimately, genetics is crucial for confirming that you're dealing with congenital TTP, not immune-mediated TTP, which ensures that patients get the correct treatment. In 2023, our ability to predict disease severity by genetics alone remains pretty limited, but I think it can be very helpful to assist with family planning when both parents are known to be carriers. I'm going to excuse myself, get a quick drink, I'll take a quick pause, and then we're going to come back and do management. All right, we talked about management. There's kind of two main ways that we talk about treatment. One of them is what's called preventative therapy or prophylaxis. The other one's called on-demand, which is treatment for acute exacerbations. The point of prophylaxis is to help manage and hopefully eliminate frequent symptoms, prevent disease exacerbations, because when these occur, they're not just uncomfortable, they're causing organ damage. And lastly, to prevent long-term damage to some of our critical organs. Who should be getting prophylaxis? In 2023, there's no consensus or guidelines on what criteria should justify when to start prophylaxis. Is it a certain number of episodes? Is it a certain type of symptoms, a certain platelet count? We don't know. There is limited data in 2023 that definitively proves that prophylaxis will reduce disease complications, but I think that's going to be changing soon. Our suspicion is that prophylaxis will reduce the number of exacerbations, reduce rates of stroke, reduce chronic organ damage to CNS and kidneys. But some of our data, as I mentioned, has been limited because it's more been looking historically rather than looking kind of future directed. This was a study, this was a snapshot from a study a few years ago, sharing what were some of the signs and symptoms that were the reason some patients started prophylaxis. You can see it's ranging from abdominal pain, fatigue, headaches, thrombocytopenia, strokes, and TIAs. And on the right, you can see some patients whose symptoms reportedly improved with therapy. So abdominal pain, only 4 individuals, they all got better. Headaches and migraines, majority improved. It's not going to be perfect. Depending on how long the damage has been occurring, it may not be completely reversible. But as a whole, this is pretty promising. It's still pretty promising. You can see we're talking 80 to 100% of people improving with initiation of these therapies. So who should consider prophylaxis? I think that it should be discussed with your physician for people with frequent symptoms, frequent disease exacerbations. I should say symptoms affecting quality of life, persistent thrombocytopenia. Again, that's a marker of ongoing organ damage. People who've had life-threatening events, a history of stroke, and absolutely in pregnancy, even if this is temporary. Let's talk about some of our different treatment strategies. Sorry, I keep moving my screen around so that you guys can see the pictures here. Talking first about fresh frozen plasma, which really was the first treatment, remains the gold standard treatment in many countries. Effective therapy for prophylaxis and treatment of acute episodes. It's burdensome, but you can give a simple plasma infusion every 7 to 21 days, depending on the patient, depending on their symptoms and their platelet count. We can use this in many different ages. You can use it in acute episodes, but it has its limitations. So typically you do have to require a lot of plasma to have a meaningful replacement of ADAMTS-13. You only replace about 1 unit for every 1 ml of plasma. And this may be inadequate for some patients, may be inadequate to kind of get them what they need to get their disease under control. It's pretty time consuming. This has to be done at a clinic, requires IV access, and really can require a lot of volume. For some patients, this can lead to volume overload, and that can cause problems with breathing and their heart function. And patients can develop some pretty severe allergic reactions that can prevent future use. It's also, again, pretty low amounts of ADAMTS-13 in each unit of plasma, or each unit of plasma. And it can be difficult to really achieve kind of meaningful ADAMTS-13 levels, or certainly kind of not just raise them, but get them to a point that they can keep people out of trouble long enough. Octaplas, some of you may be familiar with. This is also a plasma product, but it's a solvent and detergent treated pooled donor plasma product that may decrease reactions, may also decrease the possibility of viral infections. It's also effective for both acute and prophylaxis. But some of the challenges, it's not available everywhere. It's been in some shortages in the past few years. It's a little bit more expensive than FFP, and just like plasma, it has a low and variable amount of ADAMTS-13. This is a quick picture showing, what generally happens when people get a plasma infusion. So, on top, this is an arbitrary threshold of an ADAMTS-13 of 10%. Again, thinking most congenital patients have low levels of ADAMTS-13, generally less than 10%. Hypothetically, maybe it would be nice to keep them above 10%. Maybe we would see less complications at that level. And the challenge with plasma, it goes up, ADAMTS-13 goes up, and then it comes down, and so on and so on and so on. And so you can see that this person is spending, both the person in the red and green is spending, probably a day or more under that 10% threshold. The people at the bottom, they're getting this less often, every 21 days. They're spending at least half the time or more under that threshold. Is that the right threshold? I don't know. Some patients can tolerate that threshold. Some patients cannot. We have a case later to illustrate that. What ADAMTS-13 level we should aim for best disease control, it's unknown, but there is some data that maybe says maybe 10% may be beneficial. And this was just kind of showing how somebody was kind of optimizing their dose. So this is a patient on 13 units per kilo every 21 days, spending a lot of time under the 10% threshold. And in order to keep their 21-day regimen, meaning they didn't want to do it more often, they were going to have to give a massive dose. an absolutely massive dose every 21 days to keep their threshold. And this volume is not compatible. This is not technically feasible, would really cause a lot of harm to the patient. And so this was another way to kind of balance these two. What's an optimized regimen? Well, maybe we can dose similarly, but it's 13 units per kilo every 10 days. So, that's a conversation to have with your physician and the patient about, again, if your disease is really not being well managed on a 21-day regimen, well, then maybe making this alternative might result in improved disease management. In pregnancy, as I mentioned earlier, this is a specific situation where aggressive treatment is needed. Patients will typically start prophylactic plasma infusions as soon as pregnancy is confirmed, but as the pregnancy progresses, the plasma volumes often increased pretty substantially. It's often doubled to even tripled the initial volume, and it might have to be given as often as weekly. This is a lot of volume. It's very burdensome. So sometimes these women undergo what's called plasma exchange, which is not easy. It requires placement of a special IV. It's its own kind of involved way of doing large volume transfusions, but it helps manage the volume issues more safely. Another key component in pregnancy is very regular monitoring of mom's blood counts, as well as many, many, many fetal ultrasounds to monitor baby's growth. Also, multidisciplinary care, working with a maternal fetal medicine or high-risk OB, your blood bank, potentially your ICU, and so on, and many other supportive care. But I really wanted to talk on kind of some of the main prophylactic strategies. I'm hoping this will change with some upcoming technologies. Next, we're going to talk briefly about CoAT. Some of you might be using CoAT DVI. CoAT DVI, important to say from the bat, is what's called an intermediate purity plasma-derived factor VIII concentrate. This was originally developed for patients with hemophilia A or factor VIII deficiency. This is considered old technology. When we first took kind of plasma from donors and kind of filtered it down into, kind of giving patients with certain blood diseases, quote, what's missing. And this has factor VIII in it, as well as a handful of other proteins, including ADAMTS-13. But important to know, it's a pretty low amount. But when your levels are 0, even a little bit of ADAMTS-13 is probably a help. There's some major advantages, though. Unlike plasma, which can require, depending on if you're an adult, could require a liter or more than a liter of plasma. This is pretty small volume, maybe 2 teaspoons. Families can be taught to administer this at home. It is an IV medicine. It generally avoids the risk of plasma reactions and might be a nice alternative for people who've had reactions to plasma. Dosing can vary depending on the patient, their symptoms, or platelet count. And we have some data, a small series in children, really showing this is effective for prophylaxis. But some of the disadvantages are this is not a TTP medicine. This is a hemophilia medicine, but there's a small benefit in TTP. But we're delivering pretty high amounts of factor VIII, which you don't need any more factor VIII. You have plenty of factor VIII around. And there is a concern that this could potentially shift to having really high amounts of factor VIII, which can be a risk factor for blood clots. Not good. And another challenge is the exact amount of ADAMTS-13 vial is not known. There is what's called lot-to-lot variability, but we can still estimate, but it's never exact. I'll just mention briefly one called BPL-8Y. This is pretty similar to CoAT. This is what's available in Europe only. This is also an intermediate purity plasma-derived factor VIII von Willebrand factor concentrate, has been used in a series of children in the UK with congenital TTP. So just know if you ever meet individuals on an international scale, they might be using this. It's fairly similar to CoAT, although a little bit less ADAMTS-13 than CoAT. It's just what's available on a global procurement. Okay, treatment trends in 2023. In the UK registry, about 61% of patients were on prophylaxis. And in the international registry, again from 19 countries, about 71% of patients are on prophylaxis. And you can see this is, with plasma. I don't remember the exact dates, but plasma remains the main prophylaxis still being used. There are people that use CoAT and BPL, And there are some people participating in the clinical trials, which we'll talk about. This should look familiar. We're moving rapidly towards the right end of the screen, talking about recombinant Adams TS13. Okay, in terms of recombinant Adams TS13, hopefully you've had some previews on this earlier. This is currently under investigation. What I'm really hopeful is going to be something we can talk about and celebrate maybe at next year's meeting in more detail. So this has been studied more or less for over a decade. The current name of the study drug is called TAC-755. At one point, it was known as BAX 930, but then it got bought. This is, unlike CoA8, which contains factor 8 and a whole bunch of other stuff, including Adams TS13, this is solely Adams TS13. And like medicines and hemophilia, this is a small volume concentrate, 1 to 2 teaspoons, that could be given every 7 to 14 to maybe 21 days, with the hope that this will be able to be home-based therapy. A phase 1 trial, remember that phase 1 trial is about kind of initial dose finding and safety. This was completed way back in 2011. The phase 3 trial has been ongoing since 2017, and the phase 3B trial, or what's called the extension trial, is still currently ongoing. So this is a patient here on the right. This was a patient with hemophilia, and you can see he's, maybe 10 years old doing his infusion at home. And you can see just, this is about 5 cc's in this syringe. So this is a skill that takes practice to learn. This is not something you learn 1 time or 2 times, but I promise with practice, with good support from your medical team, you and your family can over time learn this skill. Okay, so I was really fortunate. There's some wonderful colleagues working in congenital TTP who are willing to share this data with me, and I really want to acknowledge them up front. So Dr. Scully from the UK was gracious enough to share her materials with me that were presented at a major meeting earlier this summer. And I'm going to share with you some of the results from the phase 3 trial. So this is a phase 3 prospective, randomized, international, multi-center crossover study of recombinant Adams TS13 in patients with TTP. A multinational study conducted in North America, Europe, and Asia. And people that participated in this study had to be between the ages of 0 and 70 with severe congenital TTP, no signs of severe TTP at screening, meaning your disease had to be kind of in control. And these patients were on prophylaxis and had a history of at least 1 TTP event and an ability to tolerate what's called standard of care, their standard of care prophylaxis. This is a study design. I'm going to make this kind of simple. First thing is, when you entered the study, you were either randomized to arm 1 or arm 2. You don't get a choice. First thing, people got a test dose of the medicine. Then we really move on to the first period 1. Period 1, if this is you, you're going to continue in the top part. You're going to continue your typical plasma regimen, prophylaxis regimen. Maybe you're on plasma, maybe you're on CoA8. We're going to follow you for 6 months. We're going to study how your disease is doing. Do you have disease problems or not? Then for the next 6 months, we're going to stop your standard of care prophylaxis and do Adams TS13 infusions. And then after that, you'll continue on Adams TS13 for another 6 months. If you get randomized to the upper arm, we're just going to do the opposite. You're going to do recombinant Adams TS13 first. Then you're going to do 6 months of whatever your standard of care was, plasma, CoA8, BPL, what have you. And then everybody comes back to Adams TS13. This is what's called a crossover, right? People generally doing the same things, but in a slightly different order, and then everybody joining together for the what's called period 3 on study drug. What were the goals of the study? The primary goal was to look at the incidence of acute TTP events, whether you're receiving the study drug, recombinant Adams TS13, or you're on prophylaxis, your standard of care prophylaxis. Secondary endpoints was learning a little bit more about some of the other clues that somebody's TTP is acting up, safety, tolerability, as well as some of the immune signals when we give a new drug. This is some definitions I think it's worth pointing out. So in this study, there's 3 categories of definitions. So let's call it an acute event. These are serious events. Drop in platelet count less than 100,000, elevation in LDH or upper LDH. And there can be other signs or symptoms. A subacute event requires at least 1 laboratory change. So either a drop in platelets of 25% from baseline, some changes in LDH, and maybe something else going on, like a fever, abdominal pain, and so on. Isolated TTP manifestations, if you have any of the following, maybe your platelets are just a little low today. Maybe your kidney numbers are changing. Maybe you have a fever. So this, again, isolated TTP manifestation, one thing, subacute, at least two things. Acute TTP, you have to have both lab criteria. Okay, who participated in the study? So these were there was 48 patients, ages 3 to 68 years old. 75% of patients were above the age of 18. You can see there was children represented as well. Pretty equal numbers, 12 to 18, 6 to 12, and under 6. About 60% female. Most people had an average Adams TS13 level of 5, but levels range from 0 to 10. And on this particular trial, 68% of patients used FFP. There were some people using octoplas as well as using factor VIII concentrates. This is again kind of showing in the analysis set, there was ultimately 46 people that were in the analysis set. This is kind of showing where different people were at different time points. There are people that kind of shift out at different points. There were people in the study that became pregnant. They needed to be removed. There were other people here that were initially screened, and then it was determined they had immune mediated and so on. So there are some individuals that were, again, did not meet the eligibility criteria. Here's the big take home. So remember, in periods 1 and 2, you either did Adams TS13 followed by standard of care, or you did the reverse. And then in period 3, everyone was on Adams TS13. Look at the difference in the rates of acute and subacute events in patients receiving Adams TS13 compared to standard of care. Patients on prophylaxis had 0 acute and subacute events, especially in individuals above the age of 12. I do not have the data for patients under 12. TTP manifestations, again, that was kind of when you have one thing, maybe just a little bit low platelets, abdominal pain, and so on. People still had signs of some disease issues, but the rates were much lower with Adams TS13 compared to standard of care. So this particular graph here, you can see kind of everything shifting over into everything except renal dysfunction, kind of shifting over into this pink box. This really is in favor of Adams TS13 over plasma or whatever people were using. Again, low platelets, that's to sign your disease is active. And they really showed that thrombocytopenia events less common when people are using Adams TS recombinant Adams TS13 versus standard of care therapy. Hypersensitivity reactions. We know that allergic reactions fairly common for patients receiving plasma and plasma-derived products. You can see in gray here in the standard of care arm, you know, a fair number of patients had hives, itching, rash, and so on. Very few events for patients receiving the Adams TS13. There were 2 patients that had itching. Hard to say what the cause of that was. You have to record it anyways, but certainly no major allergic reactions or hive-like reactions. And importantly, no anti-drug or neutralizing antibodies or inhibitors were found in these patients receiving Adams TS13 prophylaxis. That's a key point as well. So there's a few other materials I'd like to also share from this meeting. So moving on, we just talked about the results from what's called the phase 3 study, and that is still being analyzed and that data is still being followed. But after that particular study, there was a subsequent opportunity for patients who'd been on the clinical trial and been happy with that therapy to move on to what's called a phase 3B continuation study, what's called a rollover cohort, and essentially remain on drug until it is approved. And in addition to patients that were on the clinical trial and stayed on, they also did allow some additional subjects to join. And so I'm going to share a little bit of interim data about the phase 3B continuation study. So essentially it's kind of, again, same folks staying on the same drug, as well as adding a few additional people. This is really highlighting long-term safety and tolerability here, as well as, again, impact on events and TTP manifestations. Things change slightly. in the continuation cohort in terms of what subjects we're talking about. A little bit older here, these were mostly adults compared to the previous one. So, and this is important because this is where people say, well, how new is this drug? So people join at different time points. As we mentioned, some people just joined in the extension trial, other people joined at previous points. And some people, when this data was kind of analyzed, there had been patients receiving this drug for 3.5 years, up to 40 months, which I think is great. So just kind of goes to show we have some people that have now been using this drug for several years for control of their disease. Big take-home points: no treatment a side effect, no major treatment side effects or neutralizing antibodies detected, no allergic or hypersensitivity reactions, and ultimately continued to show lower rates of TTP manifestations than their previous standard of care. So on this graph on the bottom, standard of care is in the dark kind of navy or black bar. Recombinant Adams TS13 from the early phase of the study in red. That's the periods 1 and 2. Flip-flopping which version you did it. Blue is the period 3, and then the light blue is the continuation study. And these are pretty similar rates to the when they were previously using it, but still really it's pointing out from basically from their standard of care therapy, pretty significant reduction. Last thing I want to share from the meeting this year by our colleague, Dr. Catalan, who's going to be is at the meeting. It's a little bit about how this medicine behaves in the body, something called pharmacokinetic characterization. So you've seen this a few times. Again, and this time we're really actually going to be focusing on the first box. This is what I call test dose or PK assessment. So pharmacokinetics really refers to how the body interacts with administered substances, in this case, medicines. This also is what some people think about in terms of drug clearance or metabolism. How long does this last in the body? The other word we might use for this is a survival study. How long does this last before it's cleared? And we know from other medicines there can be a lot of individual variation seen, which allows us to have personalized dosing. And on a clinical trial, a PK study typically involves checking drug levels or Adams TS13 levels at various time points. So on the left or on the right is the following different individuals in terms of their Adams TS13 levels after receiving a dose of TAK-755. And on the right is individuals in terms of their standard of care treatment with fresh frozen plasma in blue, solvent detergent plasma in kind of the navy black color, and factor and von Willebrand concentrates in green. So looking at the standard of care one first, let's just look at the fresh frozen plasma in blue. So if you'll notice, I just see things all over the place. I see people whose levels are really above 10%, drifting within a day or two. I see some people whose levels are kind of like pretty low by day 3. I see a few people who are really doing pretty well all the way out to like day 5 and 9. I see a lot of difference and a lot of space between these lines. Now go over here. I see things generally following in the same smooth kind of drop off. And this is really what they showed, was that in general, the rate of decline is slower and there's less variation from person to person than there is with some of these other therapies. I think that's encouraging. When there's a little bit more similarity or sameness, it gives us better ability to predict and a little bit more control over how we may dose. So as we talked about earlier, there's kind of an emerging thought that maybe keeping levels above 10% may help reduce disease complications and disease manifestations. And compared to people receiving their standard of care therapy, individuals had levels above 10% with a study drug for a minimum of an average, of 5 days, compared to 1.7 days for people on plasma or their standard of care therapy. So the hope is that this therapy is going to allow for higher amounts of Adams TS13 levels, longer time that it lasts in the body, which we hope is going to really translate to improved efficacy. So while this is not here yet, this is really emerging as very promising therapy for prophylaxis. On this particular clinical trial, no patients had a quote acute TTP event by their definition while on prophylaxis. Individuals on the extension trial can be dosed with a dose of 40 units per kilo every 7 to 14 days with the option for home-based therapy, which would be game-changing. And compared to standard of care, it seems like it's going to offer higher and longer levels, reduced rates of thrombocytopenia, and a much lower rate of side effects compared to plasma. And there will be so much more to come on this story that hopefully we can share in the future, both about how to use this for on-demand use, patient experience, impact on their quality of life, and so on. Okay, this should be looking familiar, and I made a few additions this time around. So we talked about recombinant ADAMTS-TS13. I want to spend just a few minutes talking about gene therapy. So gene therapy for hemophilia made a lot of headlines in the past year. So in 2022, there was an FDA approved, it's called AAV gene transfer therapy approved for hemophilia B. And earlier this year, there was an FDA approval for hemophilia A. And this technology includes taking an engineered virus, completely engineered. They engineer the shell. They engineer the gene that goes inside. This creates something called an AAV vector. And it's possible that this technology might be similarly applied in something like congenital TTP. And I share this really as a story of hope because I'm hoping that we can leverage and learn from previous successes and challenges in gene therapy for a multitude of conditions, including congenital TTP. AAV therapy for hemophilia ultimately is an outpatient infusion where these engineered viruses that contain a functional factor 8 or factor 9 gene are delivered through a vein. They find their way to the liver because this almost has a shipping label on it that delivers it to the liver. Once it gets to the liver, these viral particles are basically come into the liver cells, and then it delivers the gene that's inside, which basically teaches the liver to make what it doesn't know how to do, which is make factor 8 or make factor 9. And this technology is proving to be reasonably successful. There are still going to be some tinkering and adjusting and advances with this therapy, but I think that this may be really promising for diseases like TTP, where there's a lot in common. The liver is the primary site of production of ADAMTS-TS13. So the liver really kind of has the equipment, just doesn't have the computer program to do it. So this is already being studied in congenital TTP. People have studied several different what's called kind of viral transduction strategies in mice. They've even looked at a non-viral gene transfer, so using a completely different technology, using what's called a transposon to insert a functional ADAMTS-TS13. And I won't get into the potential barriers here, but some of the challenges we've learned from other gene therapy technologies is when you're delivering a viral vector, there's the potential for a pretty significant immune response. Some gene therapies, including for hemophilia, there's concern about long-term expression, meaning you can raise levels, but only for a certain period of time. That's not what we want. We'd really like to have sustained levels. The large size of the ADAMTS-TS13 protein may limit the type of virus or kind of packaging that we need. And we are still learning what levels are good enough to provide long-term disease control. You know, aiming for normal can be really hard. Would 20% be good enough? 15% be good enough for most people? We don't have the answer to that, but I'm hoping we will soon. These are just to show you the number of gene therapy studies that have been conducted in congenital TTP to date with varying degrees of success. But I share this just because I want you to know how much is happening kind of in the scientific space for this disease population. So last take-home points about gene therapy. You know, congenital TTP is a good disease target for this technology, but it may take many more years to develop. But fortunately, we can leverage and learn from other gene therapies in development to refine techniques, learn more about kind of our optimal viral vector, or I'll say non-viral vector strategies, and so on. And I also think the myriad of things we're going to learn from recombinant um, Adams TS13 will actually help provide a lot of insights for gene therapy too about what levels we can aim for safely. Okay, I'm going to stop there and see if there's other questions. Okay, if there's time, I'm going to keep going. We're going to shift to talking about long-term complications. And a lot of these, I think we've kind of danced around to get to this point. First, we're going to talk about treatment-related complications. And again, some of this is a little bit repetitive. We've kind of talked about it as we've talked about the management strategies, but it's okay. We're just going to reinforce the messages here. So allergic reactions to plasma are not just bothersome, they can really be pretty severe allergic reactions. Admittedly, I had a hard time finding an exact number of how many patients have had, how many patients in some of these registries have had allergic reactions, but I think it's in the ballpark of probably about 5%. These can be incredibly severe and really limit the long-term use of plasma, which is really dangerous when you have somebody who has an exacerbation and you may only have plasma available. Antibodies or inhibitors. These are essentially neutralizing antibodies that can form. You can imagine when the body is making 0% of a particular protein, and now you're giving them that protein, maybe through plasma, maybe through an infusion. The body doesn't know if this is self or not self. It may recognize it as foreign. And when it's recognized as foreign, they may develop antibodies against this. We see this in severe hemophilia, and we see this in another severe form of von Willebrand's disease. This is pretty uncommon in congenital TTP, but it is always on the forefront that it is a possibility. In the literature, there's been 2 patients who had low titer inhibitors. These patients were receiving plasma infusions. And there have been other individuals who've been found to have antibodies on surveillance, but they were called non-neutralizing, non-inhibitory, meaning when I give Adams TS13 medicine, these have no impact on the clearance, which is important. There's a concept known as plasma refractoriness that I think it's important to be aware of. This is a challenging scenario where perhaps someone is having, they're having a disease exacerbation, they're getting plasma, but they're continuing to have evidence of TTP activation, that plasma is insufficient. Simple plasma infusion is not correcting their thrombocytopenia, where their kidney function's continuing to deteriorate, where their stroke is continuing to worsen. This is really concerning. And this is really a limitation of plasma in that we may not be able to achieve or maintain Adams TS13 at sufficient levels. We may not be able to measure in real time. And exactly what levels we need for certain people or various complications is unknown. There may be some situations where we might need really high levels of Adams TS13. And doing so with simple plasma can be, again, may not be technically feasible. So we might need to do plasma exchange. So traditionally, if somebody was receiving simple plasma infusions and was still having thrombocytopenia or lab manifestations, we might do a trial of plasma exchange. Somebody gets trial of plasma exchange and they're still having clinical or lab manifestations. Until recently, we really didn't have any other options. People might add in caplacizumab as a supportive care tool. That's been not been well studied. Now there have been some cases of recombinant Adams TS13 used in compassionate use to support these individuals and ultimately save their lives. Let's do another case. This is a woman who was diagnosed with congenital TTP at the age of 50. She'd had recurrent strokes at age 39 and 45, long-standing low platelets, 2 pregnancy losses. She had a few episodes of really extensive bruising in the past. She had an acute stroke, and she was treated with plasma exchange. And her Adams TS13 levels only got to about 9% with plasma exchange, which was really a lot lower than her primary treater wanted her to be. Really concerned with, multiple strokes, that she would be at risk for further. So they started prophylaxis once a week, could not maintain troughs above 10%. And while on prophylaxis, she had another stroke. This time they did plasma exchange and they were able to get her levels higher, up to 35% in the acute setting. But her provider, her doctor, was really concerned that she had another stroke while on plasma prophylaxis, and ultimately was able to receive compassionate use of this medicine to help her maintain her levels above 10%. And I just spoke with this physician earlier this week, and she said it was going pretty well. Now we talked about treatment-related complications. Let's talk about some disease-related complications. So that previous case was also kind of meant to bring us into to this topic. This is the acknowledgement that cerebrovascular events, stroke, transient ischemic attacks at an early age are common. They can happen in children and young adults, but they can happen at any age. And the rate of stroke is estimated to be about 20% by age 20, about 50% by age 50. This is, I don't know how many fold times the general population, astronomically higher than the general population. And we know that when you have stroke, it increases your risk for hypertension, which creates a vicious cycle that just further increases the risk for stroke. So aging and other things can really exacerbate this cycle. Rates of stroke are generally about, in the various registries we have, for about 20%, with about 10% of patients having a TIA. And in the pediatric registry, strokes and TIAs had happened in about a third of patients, ranging from 2 days of life to 16 years. This is a picture of a sequence of a follow-up sequence from a stroke on MRI. So overt strokes are what people kind of think about with more obvious signs like facial droop or some weakness in places, inability to speak. TIAs tend to be more brief, but unfortunately, individuals may still be having damage without these obvious signs. So this is called silent strokes, and I should have pointed them out a little bit better on this image, but I hope you can appreciate some of these kind of white dots along this is called our ventricles here, this kind of butterfly-shaped structure. And all of these are evidence of white matter damage in one of my patients. In silent strokes, patients may have never had an obvious symptom of a stroke. These may be found just by imaging surveillance, and these really clearly show evidence of damage. And these areas of damage can have really profound long-term effects. And damage to our brain is not good. This ultimately results in a myriad of symptoms. This could include seizures, cognitive impairment, which includes everything from personality changes to mood changes and depression, pain, headaches, migraines, fatigue, slow reaction time, slow word finding, difficulty doing complex tasks, which can ultimately affect our job and school performance. And while, we are still learning about the impact in TTP, this is very similar to the silent strokes we see in sickle cell disease, where we've learned a lot over the past few decades. Sorry, this is a little bit blurry in here. This was a study from the UK that looked at kind of the neurologic follow-up in individuals with congenital and immune-mediated TTP. So focus in on the column in the middle, it's congenital TTP, 12 patients versus immune-mediated TTP. So in this group of 12 patients, a quarter of them had an abnormal MRI, a third of them had persistent cognitive symptoms, but importantly, when they did what's called neurocognitive testing, many of them were found to have abnormalities. Many of them were found to have neurocognitive compromise. So this is the big take home, that patients with a normal MRI, this is supposed to be a 9, by the way, patients with a normal MRI can still show signs of damage and impairment. In the same study, these were self-reported symptoms, and this particular column includes individuals with both congenital and immune TTP. And you can see it's a variety of things that patients endorse, everything from feeling really, really exhausted and persistent headaches to feeling slow, concentration difficulties, and so on. The most common thing being memory impairment. And again, this isn't separated by disease, but there's a lot of similarities in ultimately what's occurring in terms of that damage to those precious blood vessels in our brain. So this is always pretty sobering and difficult to acknowledge. But ultimately, when we know that somebody may have some subtle issues with memory or concentration or word finding, this is what we talk about with accommodations. This is what we talk about having these assessments so we can get the right things in place for school or college or for your work environment. And acknowledge that there are more and more and more people living with health issues that do require some accommodations for them to be in their learning environment or work environment. And I think it also can open doors for also increased access and support for mental health, which is also really key. Arterial events encompasses things like strokes, myocardial infarctions, occlusions of our renal artery, the artery to our eyes. Strokes tend to be the most common type of event patients deal with. We've already talked about that. But this whole bucket of events, arterial events, in the hereditary registry was seen in all ages. About a third of patients had dealt with this. But by when patients get to be older, 40 to 50 and upwards, 50% of patients have had one of these events by then. Myocardial infarction or heart attacks are relatively infrequent. Only 5 individuals out of 120 in the hereditary study and 0 in the UK study had an MI. So the coronary arteries do seem to be not, the highest risk organ. But again, this is also many of these individuals are quite young in these cohorts as well. The blood vessels in the kidneys are particularly susceptible to damage as well. In the Japanese cohort, 7% of people, when we met them, had kidney injury, 9% with chronic kidney disease. In the international study, apologize for my typo here, in the international study, it's a little bit higher. Again, there's ethnic differences in rates of kidney disease between individuals of Japanese and Asian descent and a kind of mixed European background. A quarter of individuals with some evidence of renal damage, 10% of individuals needing dialysis, and even several needing kidney transplant. What's the impact of all these comorbidities on prophylaxis? You know, this is where it's challenging. As of right now, we really don't have any prospective studies to date, but our clinical trials that are underway will help illustrate some of these things. But our registry studies historically have indicated lower development of kidney disease, stabilization of kidney function, reduced number of exacerbations, and improvement in things like pain, headaches, fatigue, and so on. And ultimately, I think myself and everyone at this meeting is incredibly optimistic that recombinant ADAMTS-TS13 is going to demonstrate effectiveness on prophylaxis and with superior efficacy from previous therapies. This is my last slide. Thank you for staying with me this whole time until my voice is getting tired. But I really want to thank all of you for being here and for being part of this amazing group of scientists and clinicians and patients and caregivers and family members and supportive team members. It really takes a village to support the work that's being done. We all have a role here. So I encourage you, participate where you can to tell your story, because every single patient and everyone's story really counts in helping us answer more questions. I'm sorry I can't be there to answer questions live, but you're in great hands with the folks who are there. Enjoy the meeting. I hope to meet you at some point. Take care.